Assalamu alaikum, everyone. My name is Aboussekhra. I'm a second year medical student. And today I'll be explaining lecture 10 and 11, acid-base disturbances and their compensations 1 and 2. Inshallah, this lecture will be easy if you understand the concepts. But feel free to ask me any questions during or after the session. So let's begin. So these are the learning objectives that you're supposed to know. I took them from Dr. Angelica's slides, but these are the same ones. Inshallah, by the end of this file, you'll be familiar with all of them and you'll be able to answer anything, inshallah. So before we start with the disturbances, these are some numbers that you need to keep in mind and you need to remember. And Dr. Angelica emphasized so much that you need to remember these. So these are the normal pH, which is 7.4, the normal PCO2 of the blood, which is 40, and the normal bicarbonate concentration, which is 24. Please remember these, like it's very important, and because any change in any of these numbers is going to cause an acid-base disturbance. Okay, so what is an acid-base disorder? It's basically a clinical condition where you have a change in the concentration of hydrogen, which is reflected and can be seen in a change in the pH of the blood, okay? And we have two types of disorders. You can either have acidosis or alkalosis. Acidosis is when you have an increase in the hydrogen ion concentration, and that means you're gonna have a decrease in pH. And alkalosis, you're going to have a decrease in the hydrogen ion concentration, which is an increase in pH. Okay. The acidosis and alkalosis can happen by two mechanisms, either by respiratory or metabolic mechanism. So you should remember that if there was a change in the CO2, you're going to see a respiratory disturbance. And you should remember that CO2 is an acid, okay? So think about it logically. If CO2 is an acid and it increases, obviously it's going to cause acidosis, okay? And if it decreases, it's going to cause alkalosis, okay? And these both these acidosis and alkalosis are going to be respiratory because CO2 is a volatile acid. It's mainly controlled via the lungs, so it's a respiratory disturbance. On the other hand, bicarbonate is what controls the metabolic disturbances. So if you see a change in bicarbonate, you know that this is a metabolic disturbance. You should also remember that bicarbonate is a base. So if you increase the base, what is that going to do to the blood? Obviously, you're going to have alkalosis. If you decrease a base, you're going to have acidosis. Make sense? Okay. So this is an important rule that you should remember. Again, Dr. Angelica really emphasized on this, so you should really remember it. ROM. So let's break it down. What does ROM stand for? So the R and O stand for respiratory opposite. What does that mean? It means that if there was a disturbance in the respiratory, and we said what causes a respiratory change? CO2. So if there was a change in CO2, you're gonna have like an opposite effect on pH. So basically, if we have an increased CO2, you're gonna have a decrease in pH. So that's what respiratory opposite means, okay? So increase CO2, decrease pH. And obviously the other way around. Like if you have decrease in CO2, you're gonna increase pH. Let's look at the other part of it, the MA. Metabolic equal. Basically means that the metabolic change, which we said was caused by the bicarbonate, if there was an increase in bicarbonate, pH is going to increase. So it's the change is in the same direction. So increase. And for example, if it decreases, pH is going to decrease. And this makes sense. Why? Because as I said, CO2 is an acid. So obviously, if it increases, pH is going to decrease. And same thing. So respiratory opposite. For metabolic equal, like if bicarbonate, which is a base, increases, then pH is going to increase. So just think about it logically. Okay. The rules of compensation. These are very important rules that you need to know. Basically, when you get a disturbance in your pH, the body wants to compensate because it wants to maintain homeostasis. So basically, compensation doesn't happen like anyway. There are some rules that compensation needs to follow. So what are those rules? So basically, if the primary disorder is metabolic, compensation will be respiratory. What does that mean? Basically, if the primary disorder happens because of metabolic change, so basically a change in bicarbonate, the compensation needs to happen via the other system. So it's going to be respiratory. So the compensation is going to be a change in the CO2. Again, the second rule is the opposite. Like if the change was in CO2, which is respiratory, the metabolic or the renal system is what's going to compensate. So it's always the other system that's compensating. Okay. The third rule, very important, is that the compensation needs to be in the same direction as the original disturbance. What does that mean? Let's take an example. If, for example, we have a respiratory change, so for example, we have an increase in CO2, okay? The compensation, as we said, needs to come from what? The renal or the metabolic system. So bicarbonate is going to change. But how is it going to change? It needs to be in the same direction as the original disturbance. This is the original disturbance. It increased. So the compensation needs to also increase. So the bicarbonate is also going to increase. Okay? Does that make sense? Okay. So yeah, just keep that in mind. So compensation happens if the primary disorder is metabolic, the compensation will be respiratory and vice versa. And the compensation needs to always be in the same direction as the original disturbance. So if the disturbance was increase, the compensation will be increase. If the disturbance was decrease, then the compensation will be decrease. Okay. So now that we're done with the basic rules, let's get into the actual disturbances. So the first one we have is respiratory acidosis. Okay, how does it happen? It basically happens when we have decreased CO2 removal from the lungs, or when we have accumulation of CO2 in the lungs. So basically, we're not taking out the CO2 out of the lungs, okay? This happens when we have, for example, hypoventilation. We're basically not breathing out the CO2 enough. So the CO2 accumulates and it increases, okay? So this happens in conditions like the damage to respiratory centers, pneumonia, chronic bronchitis, airway obstruction, pulmonary edema, and decreased pulmonary membrane surface area. So any condition that's going to cause like decreased removal of CO2. We can also have asthma. Asthma could also cause respiratory acidosis. So yeah, so let's look at the actual disturbance and what actually happens. So basically, the disturbance is that we said we have decreased removal of CO2 from the lungs. So CO2 is going to accumulate. So that means CO2 is going to increase. And we said, let's remember Rome. So respiratory opposite. So the disturbance is increased. CO2 is increasing. So the pH change needs to be in the opposite direction. So you're going to have a decrease in pH. Okay. And the compensation, what is the compensation? The kidneys are going to compensate for this disturbance because we said it needs to be the other system that's compensating. So the bicarbonate, what's going to happen to it? Again, remember the rules. The compensation needs to be in the same direction as the original disturbance. The original disturbance was increased. So the compensation needs to also be increasing. So this again makes sense. Why? Because if CO2, which is an acid, increases in the blood, it's going to cause an acidosis. If we want to compensate for that, we want to increase the base to neutralize it. Okay. So yeah, this is respiratory acidosis. Let's go to respiratory alkalosis. So this one is just the complete opposite. It's caused by an increase of CO2 removal from the lungs. So basically, you're taking out a lot of CO2 from the lungs, and you don't have enough in your body. So this is caused in conditions where you have hyperventilation. So you're breathing out so much CO2. For this happens in conditions like emotional disturbances like panic attacks, where you're hyperventilating. Drug overdose can also cause hyperventilation. High altitudes, this happens because In high altitudes, you have a decrease in the partial pressure of oxygen. So your body compensates by making you hyperventilate to get more oxygen in. All of these conditions are causing hyperventilation, basically. So let's look at the disturbances. Again, so the disturbance is that we're removing a lot of CO2. So basically CO2 is decreasing. Again, remember Rome, respiratory opposite. So since this is decreasing, pH is going to increase. So we have alkalosis. And then the compensation, it needs to be metabolic, so bicarbonate. What's going to happen to bicarbonate? It's going to decrease. Why? Because CO2 decreased, and the compensation needs to be in the same direction. Okay? Let's move on to the next disturbance. So metabolic acidosis. How does this happen? Metabolic acidosis happens when there's decreased bicarbonate concentration in the extracellular fluid. Obviously, if you decrease the base, which is the bicarbonate, you're going to get acidosis. This happens in multiple conditions, like the failure of kidneys to excrete metabolic acids. So like there's so much acid in the blood. Ingestion of acids like methanol and aspirin. Metabolic production of acids like in lactic acidosis. Diarrhea. In diarrhea, you're basically losing the bicarbonate. So yeah, that's why it causes acidosis. Malnutrition and starvation. And loss of bases when you're losing bases, like in renal tubular acidosis, chronic renal failure, Addison's disease, diabetes mellitus, where you have ketoacidosis. So all of these are going to lead to metabolic acidosis. And by the way, for these conditions, you don't need to like memorize or know like what each one is specifically. Just be able to recognize it to know that this condition will cause this specific disturbance. But mainly focus on this, like the disturbance and compensation. But let's get to that. So in metabolic acidosis, what is the disturbance? We said we're going to have a decrease in the bicarbonate. Okay, so decrease bicarbonate. Again, remember Rome, metabolic equal. So since this is decreasing, pH is going to decrease. The compensation, we said since the original disturbance was metabolic, the compensation needs to be respiratory. What is that? CO2. What's going to happen to CO2? It's going to decrease. Why? Because the compensation needs to be in the same direction as the original disturbance. Okay? Okay. And for the final disturbance, we have metabolic alkalosis. In metabolic alkalosis, you basically have the opposite as metabolic acidosis. So you have an increase of bicarbonate in the extracellular fluid. And this happens when you take diuretics. Diuretics cause excretion of hydrogen. So you have like diuretics cause an increase of reabsorption of bicarbonate, excess aldosterone, vomiting of gastric content. So basically, when you're vomiting, you're removing acid. So that's going to cause alkalosis. Ingestion of alkaline drugs. So yeah, all of these conditions cause metabolic alkalosis. So yeah, something to remember, vomiting will cause alkalosis, diarrhea will cause acidosis. So, because diarrhea, you're losing base, and vomiting, you're losing acid. So just remember, try to differentiate between the two. So what is happening in alkalosis? The disturbance is that you have increased bicarbonate, which is going to lead to an increase in pH. Again, just keep remembering the same rule, which is Rome. Metabolic equal. They're going to be the same. The compensation, again, just keep remembering the rules. The compensation is going to be from the respiratory, so CO2, and it's going to increase because the original disturbance was increased. Okay, now that we're done with the individual disturbances, sometimes we can have something called a combined disturbance. This basically happens when you have a problem in both systems, the respiratory and the metabolic. Like for example, someone that has asthma, which is going to cause respiratory acidosis, and at the same time they have diabetes mellitus, So that's going to cause metabolic acidosis. So together, they're going to have respiratory and metabolic acidosis. So basically, in combined disturbances, the CO2 and bicarbonate change in opposite direction. What does that mean? It's basically, remember how we said that the compensation needs to be the exact same as the original disturbance. So if one increases, the other should increase too. So in the combined disturbances, we don't have that. One would go up, the other would go down. So we can see it here. So in respiratory and metabolic acidosis, pH is going to go down, obviously, because acidosis. CO2 is going to go up. If you remember in the Rome respiratory opposite, so it's going to go in the opposite direction and cause acidosis. And bicarbonate is going to go down. So as you can see, these two are going in completely different directions. This is what causes the combined disturbance. And alkalosis is just the opposite. So you have an increase in pH, a decrease in partial pressure of CO2, and an increase in bicarbonate. Okay, so why are we studying this disturbances? Like, why do we care? It's basically the effect of alkalosis. Alkalosis can be really lethal to the human body if not controlled or compensated. So basically what happens when you get alkalosis, that's going to activate the potassium hydrogen pump. Why? Because if there's alkalosis in the blood, the cells are going to try to compensate by kicking out the hydrogen ions to the blood to neutralize the pH. But when that happens, there's so much hydrogen coming out and so much potassium going in, and this potassium obviously is a positive ion. So when it goes inside of the cell, it's going to cause the membrane to depolarize. And that's not good because we're going to have overexcitability of the central and peripheral nervous system. And that can be bad. Why? Because it can cause muscle tetany, which is like multiple contractions. It can cause convulsion, and it can cause respiratory arrest, which can often lead to death. So this is why it's really important to understand these concepts. Okay, so now that we know all of the disturbances and what goes wrong in each one, how do we evaluate these disturbances in the clinic? Like when a patient comes in, how do we know that this person is experiencing an acid-base disorder? So we order their ABGs, which are ABG basically is the acid-base gas. ABGs are the arterial blood gases, which are what we already took: the pH, the partial pressure of CO2, and the bicarbonate. These are all the ABGs. So you examine them, but first you examine the pH. So the first thing you look at is the pH. It's going to basically tell you whether this person is having acidosis or alkalosis. And then you look at the CO2 and bicarbonate to determine whether the disturbance is respiratory or metabolic. So let's practice. I want you guys to interact, please. If you guys know the answer, if you can open the mic and answer, that would be amazing. So this is the first set of ABGs. So we have a decrease in pH, an increase in CO2, and an increase in bicarbonate. Can someone tell me what this person is experiencing? Okay. Um, I'll tell you. So basically, this person, they have a decreased pH. What does that indicate? It means that this person is having acidosis. So that's out of the way. So we look at the pH first. We know that they have acidosis. Then we look at the CO2 and the bicarbonate. So let's look at the CO2. CO2 is increased. Here we try Rome. So Rome, respiratory opposite. Does that match? Yes, because the CO2 increased, the pH decreased. So yes, Rome is working. So we know right away that this person is having a respiratory acidosis. And then we look at the bicarbonate. The bicarbonate is increased. Let's see if this is a compensation. It needs to be the same as the original disturbance. Is it? Yes, it is. Bicarbonate is increased. CO2 is increased. So that means that bicarbonate is compensating for the CO2. So yeah, this person is having respiratory acidosis. Okay, for the second one, I gave you numbers. This is why in the beginning of the lecture, I said that it's really important for you to know the normal values so that you know if there was a change. Okay, so let's analyze what this person is going through. So 7.6, is this above the normal, below the normal? It's above the normal. So we have alkalosis. So we know that this person has alkalosis. But let's see, is it respiratory? Is it metabolic? So we look at the others. So CO2. CO2 is 25. The normal we said is 40. So CO2 is decreased. Okay. Does that match with Rome? Respiratory opposite? Does that work? Yes. Since this one is decreased, this one is increased, that works. So this person is having a respiratory alkalosis. But let's look at the third one. Let's look at bicarbonate. It's 34. The normal was 24. So that means this is increased. Let's try Rome. Metabolic equal. This is increased. This is increased. That also works. Okay. What does that mean? If both parameters work in Rome, like respiratory opposite, metabolic equal, if both are working, and obviously this one is increased, this one is decreased, we can tell that this is a combined alkalosis, combined respiratory and metabolic alkalosis. Okay, so for the third one, I tried to give you all the options that she could ask you about. Like she could give you the arrows, she could give you numbers, she could also give you this where she gives you a diagnosis and you have to know. So for this one, we have a patient that presents with diarrhea. Which of these is correct? And then we were given the ABGs to determine what this person has. So in this question, you have to know that diarrhea is a specific acid-base disorder. So diarrhea, as we said, is a metabolic acidosis. So metabolic acidosis. Now that we know what diarrhea is, we have to look for metabolic acidosis in these options. So let's look at the first two. The first two, the pH is increased. But that means alkalosis. So right away you can eliminate the first two options. Look at the last two. So pH is down. So that means acidosis. So okay, we can consider them. Let's look at C. So CO2 is decreased. Let's try Rome. Respiratory opposite. Okay, it doesn't work out. It's not opposite. They're both decreased. So let's look at the bicarbonate. Metabolic equal. Yes, they're equal because the bicarbonate is going down and pH is going down. So that means that this one is the correct answer because it's a metabolic acidosis. And CO2 here is compensating because it's in the same direction as the bicarbonate. Okay, so yeah, we can tell that the C is the right answer. D is not correct. Why? Let's see what D is. D is acidosis. We said that. CO2 increased. Respiratory opposite. That means that works. So what does this person have? This person has respiratory acidosis. That's why it's not correct. And C is the correct answer. Okay. So basically, when you have an acid-base disturbance, there are levels to like how far along it is. So you can have an uncompensated or an acute acidosis or alkalosis. This is basically when the disturbance first happens. So the pH is abnormal, obviously, because we have a disturbance, and the organs that are supposed to compensate, like the lungs and the kidneys, they still haven't begun correcting the imbalance. So this is what uncompensated or acute means. The partially compensated acidosis or alkalosis is when the pH is still abnormal, but it's going towards normal. Why? Because the organs, the lungs and the kidneys, have started to correct the imbalance, but they're still working towards it. So it's going towards normal, but it's still abnormal. And finally, we have the completely compensated acidosis and alkalosis. You can see that the pH went back to normal, and the organs are very active, and you can recognize their activity by seeing that the bicarbonate and the CO2 concentrations are very abnormal. But that's fine. They eventually go back to normal. It's just when they're trying to compensate, there's obviously going to be like an abnormal thing happening to them. So yeah, that's it. So these are the disturbances. Now for this diagram. Okay, so this diagram, basically you can see all of the disturbances that we talked about on this diagram. And it might seem complicated, but trust me, if you understand how to analyze it, it will be really easy. Okay, so let's break it down and all of the components that we see over here. So we have the x-axis, which is pH. So obviously this is the normal, 7.4. Anything below it is going to be acidosis. Anything above it is going to be alkalosis. The y-axis is the bicarbonate concentration. Again, you can see the normal. And these lines, the curvy ones, these are the partial pressure of CO2, and they're called isobars. Why are they called isobars? Because on each isobar, you have a set number of partial pressure of CO2. So if you were moving along this line, the partial pressure of CO2 is not going to change. It's going to remain at 20. Again, this one is going to remain at 40. This one's going to remain at 80. And by the way, like having 3 lines doesn't mean like these are the only 3 lines that are present. Like normally, like you have just a bunch of lines for each value, but this is just to simplify it and so that it doesn't look too crowded. Okay, so now that you know, and the last part of the diagram is this line. This line is called the buffer line. And on it, it's where the buffer, or which is bicarbonate, is normal. Okay, so at the intersection of all these components, we have the normal point. So right here is where the normal point is, where you have normal partial pressure of CO2, where you have the normal pH, and you have the normal bicarbonate. So if you deviate from that normal point, you're going to start seeing the disturbances. So let's start with point number A. Point A, if you look at it, it's on the buffer line. And if you notice on the buffer line, we have that like the bicarbonate doesn't really change. What changes if you move along it is the partial pressure of CO2. And from what we studied, if the partial pressure of CO2 changes, what does that mean? That we have a respiratory problem. So if there's a point along this line, anywhere along this line, you immediately think of respiratory disturbance, okay? Whether it's acidosis or alkalosis depends on like where it is compared to the pH line, but immediately think of respiratory. So point A, for example, if you look at it, it's on this side of the pH, so it's less than the normal. So you immediately think there's there's acidosis. And since it's on the buffer line, we know that it's respiratory acidosis. And you can see that also by looking at the CO2. It's at the 80 partial pressure of CO2, 80. So that obviously tells us that there's a respiratory problem. But since it's on the buffer line and bicarbonate didn't really change, that tells us that there wasn't a compensation. Bicarbonate still didn't compensate. So we can deduce that point A is an uncompensated or an acute respiratory acidosis. Does that make sense? Okay. So again, any point on this line is going to be respiratory. So point I is again on the line, so it's just the opposite of A. And since you just look at the pH first, you see that it's on this side, so you can tell that it's alkalosis. and you can see that it's on the line, so you know that it's respiratory alkalosis. And you can also see that by looking at the CO2, it's decreased, so that's obviously going to be alkalosis. And since on the buffer line, the bicarbonate didn't change, so you can tell that it's an acute or uncompensated. Okay, so that's for point A and I. Any point on the buffer line is going to be the same. Now let's look at the points that are on this one, the normal pressure of CO2. For this one, let's take point D, for example. Point D is on the isobar that's normal. Okay, so CO2 is normal. What's changing when you go along the isobar? Not CO2, because CO2 stays the same. We said it's called isobar because the CO2 is not changing. What's changing? The bicarbonate. So if you move along this line, you're changing bicarbonate. So you can either go like higher than normal or lower than normal. So if we take point D, let's look at the pH. It's basically on this side, so we can tell that it's alkalosis. And since CO2 isn't changing and bicarbonate is the one that changed, and it's obviously higher, then you can right away tell that it's metabolic. It's the same idea. So basically, if there's a line on this one, the buffer line, the problem is going to be respiratory right away. And if there's a point on the isobar that's normal, then it's a problem, it's a metabolic problem right away. You don't even have to think about it. It just depends on whether it's acidosis or alkalosis, depending on where it is compared to the pH. So point D is a metabolic alkalosis that's uncompensated. Why? Because the CO2 is normal. Okay, the CO2 didn't change. So it's uncompensated. So that's point D. Point F is just going to be the opposite. It's going to be a metabolic acidosis. That's acute. Okay, now that we're done with the normal isobar and the buffer line, let's look at the other points that are on the graph. So let's take point B, okay? So when you're looking at points on the graph, you can use the same like clinical evaluation test where you look at pH first and then you look at CO2 and bicarbonate. So if we look at point B, on the pH, it's less than the normal. So we can tell that there's an acidosis happening. But let's look at the components. Let's look at the partial pressure of CO2. It's 80. What does that mean? Increased. So we have increased partial pressure of CO2. Okay, so if you do Rome again, respiratory opposite. So basically CO2 is increased, pH is decreased. Does that work? Yes, it works. So we basically have a respiratory acidosis. Now finally, let's look at the bicarbonate. You would look at it. Okay, it's here. Let's look at it. It's above normal. So we can tell that it's increased. Okay, so we have an increased bicarbonate. Again, let's see, does that work with the compensation rule? CO2 is increased and the compensation or bicarbonate is increased. So that works. So we know that point B is a respiratory acidosis that was partially compensated. Okay, why partially and not completely? Because the pH is still abnormal, like we said here. So in partially compensated, the pH is still abnormal. So yeah, that's point B. It's why is it respiratory? Because because CO2 is increased. Why is it acidosis? Because the pH is decreased. And yeah, the compensation is the bicarbonate being increased. Okay, so that's point B. Let's take another point. Let's look at point C. So point C, if we start to look at it, we look at pH. It's kind of normal, right? It's really close to the normal. So okay, let's say that pH is normal. And then let's look at the other stuff. Let's look at CO2. CO2, let's say that this is, for example, 60, like partial pressure 60, since it's between the two lines. So basically we have 60 is increased. So okay, that means it could be like it's CO2 is increased, but pH is normal, so we can't really make an assumption. The bicarbonate, let's look at it. It's also increased. So you have increased CO2 and increased bicarbonate. So in this case, it's basically a fully or a completely compensated disturbance. Why? Because the point is at a normal pH. So the pH was brought back to normal, like here, as I said. So a completely compensated acidosis, the pH goes back to normal. But there's still a disturbance in the CO2 and bicarbonate because the organs are trying to compensate. So we can't we can't like know for sure what caused the issue. We just know that there was an increase in CO2 and an increase in bicarbonate. So you just need to think about a condition where we have both increased CO2 and increased bicarbonate. That could be a respiratory acidosis where we have increased CO2. And the compensation is that we have increased bicarbonate. Or it could also be a metabolic alkalosis because you have increased bicarbonate and the CO2 increases to compensate. So point C, if like you want to know what it is, it's basically a fully or completely compensated either respiratory acidosis or metabolic alkalosis. So it could be one or the other. We can't really know because the point is at a normal pH, and so we can't differentiate. And the other points on this diagram are like I basically talked about like all the options that you could have. So it's gonna be one of these options. So either acute or partially compensated or fully compensated. So yeah, these are all the points if you want to look at each one and what it is. And this is exactly like what I told you. To basically, you have to look at the pH first to determine whether it's acidosis or alkalosis, and then look at the bicarbonate and CO2 to determine what caused it. And yeah, that's it. Now we're basically almost done with the lecture. That was like mostly the bulk of it. I just have like a few more points that I need to tell you. So basically, this slide is talking about like what the kidneys do in acid-base balance, like what's their role. Basically, kidneys help in removing the non-volatile acids that are added daily. Like, for example, lactic acid, and there are so many acids that are non-volatile that are added to our body. And the kidney is what keeps the pH normal and helps us like get rid of them and make sure there's a balance. The kidney does that by first of all conserving the filtered bicarbonate. That basically means like the kidneys reabsorb the bicarbonate, so to maintain like the bicarbonate buffer, because we don't want to lose the buffer. You guys should know by now what a buffer is. The kidneys also regenerate new bicarbonate ions, like again to replenish the lost bicarbonate. And they also secrete hydrogen into the urine. So if, for example, like we have acidosis, kidneys will secrete the hydrogen so that like to bring back the balance and neutrality. Okay. So these are some transporters that are found in the kidney that help in maintaining the balance. I'm pretty sure you guys already took this in another lecture, so I'm just going to go over them quickly. So we have the apical sodium hydrogen antiport, the basolateral sodium bicarbonate symport, the hydrogen ATPase, the hydrogen potassium ATPase, and the sodium NH4 antiport. So all of these help in maintaining the balance. And then we have the intercalated discs, intercalated cells. These are also very important in acidosis and alkalosis. I'm pretty sure, again, you already took this. So type A intercalated cells are important for acidosis, and type B cells are important for alkalosis. You can remember this by like type A for acid, and type B for base. So yeah, you can remember it that way. So type A cells, they're important for acidosis. Why? Because they excrete hydrogen. So obviously, if we have acidosis, we have increased acid in the blood. So they want to excrete the hydrogen to maintain the neutrality. And they also reabsorb the bicarbonate and potassium. Again, all just to bring back the acidosis to the normal level. Type B cells, as I said, they play a role in alkalosis. They just do the exact opposite. So they reabsorb the hydrogen ions, and they excrete the bicarbonate and potassium. And yeah, that's it for the intercalated cells. And now for the final concept in this lecture, the anion gap. So what is it? The anion gap is basically a number that we calculate. So this is the formula. Remember the formula, please. You should memorize it because you could get questions like to calculate the anion gap. So it's basically in our blood, we have cations and we have anions, okay? The cations are like sodium, potassium, but sodium is the major one, so we just count it as sodium. We also have the anions, which are like chloride, bicarbonate. But if you measure just these two, they're not going to equal the sodium. And we need there to be like a balance and electroneutrality between the anions and cations. So if we calculate it, like we take the sodium, okay, minus the chloride plus the bicarbonate. So these two, and we calculate it, we're gonna get this anion gap. It's a number that ranges between 8 and 16, and the average is 12. It's basically any unmeasured anion in the serum or plasma, like proteins, phosphates, like lactate, citrate, sulfate. All of these, they're unmeasured, and they're what represent the anion gap. So yeah. What do we need the anion gap for? Like, well, how do we use it? We basically use it to identify the causes of the metabolic acidosis. Basically, metabolic acidosis can happen in two ways. Either an excess of acid, either by like excess production of acids in metabolism or ingestion of acids, or it can happen by loss of base. So the anion gap can help us identify which one of these causes is the one that caused the disturbance. So basically, like how does it work? When we have low bicarbonate, basically in metabolic acidosis, we have low bicarbonate. We want to maintain the electroneutrality between the anions and cations. So what we do, or like what happens, is either one of these, either the anion gap or the chloride needs to increase. And whichever one increases is how we determine which one is the problem, or like what caused the problem. So yeah, so obviously, like when we have metabolic acidosis, there's going to be low bicarbonate, and the sodium is not going to change. So we want to maintain the electroneutrality. So either chloride or the unmeasured anion, which is the anion gap, is going to increase. So these are the two cases. If chloride remains unchanged, if chloride doesn't change, what is going to change? The anion gap. So that basically means we have extra unmeasured anions. And that basically occurs when we have excess acids, like in diabetes mellitus, where we have ketoacidosis, so extra acids, lactic acidosis, when you ingest aspirin, methanol, ethylene glycol, or in chronic renal failure. So basically in all of these, you have extra acid or extra unmeasured anions, okay? And if this is the first case scenario. In the other case, chloride will increase. So if chloride increases, the anion gap will remain unchanged. So the anion gap will remain normal, and it's chloride that increases. This is called a hyperchloremic metabolic acidosis, because hyperchloremic, we have extra chloride, because chloride increases. This happens in renal tubular acidosis and in diarrhea. So when chloride increases, it basically indicates that we have loss of bases. So this is the use of anion gap. One will tell, like it will tell you what caused the metabolic acidosis. So these are your two cases. Okay, so we're done. We're basically done with the lecture. I just wanted to ask this question to finish it off. It's basically the following clinical laboratory data is obtained from a patient with diabetes mellitus. So plasma sodium is 138, plasma bicarbonate is 8, plasma potassium is 6.5, arterial hydrogen ion concentration is 75, chloride is 102, and glucose is 580. Which of the following correctly reflects this patient's anion gap? So this question is very simple. I know the numbers might seem scary, but it's very simple. You just have to use the formula of the anion gap to calculate it. And don't let the extra numbers scare you or bother you. Some of these numbers are just like extra. So you just need to focus on 3 numbers, which are the sodium, the chloride, and the bicarbonate. These are the ones you need to calculate the anion gap. Does anyone want to throw a guess on what the answer is?
Is it B?
It is actually B. Can you tell me how you got it?
So I used the Na plus concentration 138 minus Cl minus and minus HCO3 minus. So 138
Yes,
minus 102 minus 8.
exactly. So that gives you 28. So that's it. So you basically just use the formula, get the answer, and that's it. So it's an easy question. And that's it for this lecture. Thank you guys so much for attending. Please scan the QR code for the feedback. And of course, if you have any questions, feel free to ask me.